London with people with mental health and substance use problems back in the late 90s, and I had one of the original dual diagnosis roles, as they were called back then. And then from that springboarded my career into academia and into my PhD around training mental health staff to work with people with severe mental illness and substance use. And that's kind of been a big part of my career.
What's your sense of where we're at now in terms of helping people with mental illness and substance use issues?
Yeah, so I think it's gone in waves, I would say. That when I first started out, nothing was happening, and it was a real uphill battle to get anything done in terms of coordinating care between mental health and substance use. We hadn't had a government guidance at that stage in the late 90s, that came in 2002. There was a national programme which was fantastic, and there was regional hubs where we looked at implementation. This is in England, of course. But then that ended, so the national programme ended, and then it's been kind of held together more by volunteers than by any sort of funding, and we've managed to survive the last few years, but it feels like now there's a bit of a resurgence of interest in the topic, and I think with integrated care there's a real opportunity now to kind of really think about how integrated care can actually facilitate more joined up working for this group as well. So I think we're on the cusp of maybe some new initiatives and some new change.
People with mental illness and addiction problems generally haven't been the number one priority over the last 20 or 30 years.
Yeah, I think it's quite surprising. It's surprising from my point of view why that has been so, because we know that the consequences of having not just substance use, mental health, but usually comes with a whole array of multiple needs, why we haven't got better at addressing that. But I think, and as we'll talk about more today, I think there's issues around leadership, workforce development opportunities, and bringing the services together to work more effectively together. Those key elements are critical, and they're just not working at the moment. We've got a problem with how we train people. We train people in silos. So if you're a mental health nurse, you look at mental health. Substance use, if you're lucky, you might have a little bit of add-on sessions, but for example, you might only have half a day in your entire 3-year programme, so that's a problem. The same in substance use, they don't have mental health backgrounds, so therefore they struggle to recognise and help people with comorbid mental health problems in substance use. So actually we've all got the skills, but we just need to bring them together and share them. And a good example of how that can work is local networks, where you have representatives from all the services who all work together to kind of share their knowledge and the remits of their service, and generally it just becomes more slick, basically.
Yeah.
So we wanted to understand what was going on in the UK, we wanted to find service models, and then we wanted to kind of understand how they were working, in what ways, and all the mechanisms involved in that, and resource, and including staffing and time and things like that.
And what did you find? What's going on? It's very patchy, I imagine.
It's extremely patchy, extremely patchy. We did a big mapping exercise. We found some services where they've actually commissioned posts. So that was our criteria. And then we looked at those 6 case studies, and we kind of described them, and then we interviewed staff, service users and carers in each of those areas, using the realist framework that we developed from a synthesis of evidence. Then it was quite a directive, it's not such open-ended qualitative research, it's quite directive, and we wanted to unpick some of the things that make it work. So I guess at the end, the RECO study's got some positive findings about what actually can work and what works well from both the staff point of view, but also from the people who receive that service as well. So a lot of the research around dual diagnosis is often quite negative about what's not working and all the adverse consequences. So we feel we've got a fairly positive message to impart.